Assalamu alaikum. Let's start our today's session. We have a male patient named Mr. Ahmed. He's 35 years, came with complaint of dizziness. Let's start the case after sharing the timer. The timer is clear for all?
Yeah.
Yes.
Yeah. Let's start.
Hello, Mr. Ahmed. This is my name Almanla. I'm one of the medical doctors in the clinic. May I confirm that you are Mr. Ahmed and 35 years old?
Yes.
Nice to meet you, Mr. Ahmed. It came to my knowledge that you are complaining of some sort of dizziness. We're here to speak about your condition and take history. I will write notes. It will be totally confidential between us, if that's okay.
Okay.
Can you tell me more? What do you mean about that? What happened?
Actually, since about 4 months, 3 to 4 months now, I have this business. I feel that the objects rotate around me, doctor.
Okay. Do you feel your lightheaded, or what exactly?
I feel nausea and some nausea and some feeling sick, and I saw that that object rotate around me, doctor.
Okay, you mean spinning objects around you,
Yes.
spinning. Okay,
Yes.
okay. I'm sorry for that. Can you tell me when it started exactly? 4 months. Sorry, I
About
didn't.
3 to 4 months. Yes.
Yeah, when it
4 months.
started, I mean, and now, is it worsening or improving or
Yes,
the same?
doctor. Yes, it's worsening.
Worsening, okay. And does it come and go or all the time, most of the time?
Actually, at the first it was come and go. Now it usually all the time. Present all the time.
Okay. And I know this. Okay,
أنا
is it?
قفلت منه طبعا.
Hello? This must be
Hello?
affecting you so much, right?
Yes, doctor. Actually, it's my
Okay,
life.
I'm sorry for that. Can I know, did you have any kind of trauma?
No, doctor.
So, okay, any pain anywhere?
No, doctor.
Okay, so this vertigo and feeling sick, I mean, this spinning, do you feel any, did you throw up?
No, I only feel feeling this. For
Okay.
seconds, doctor. It usually comes to me when I try to stand from sitting position.
Okay,
Or
for
when
seconds.
I lying down and I woke up very in hurry.
So
I
what
feel that
improves? Yeah, you feel what improves it exactly?
I didn't notice anything that improved it. Maybe slow motion. يعني I
Okay.
try to slow up my motion and slow movement.
Yeah.
To
What? What worsens it then?
what it? Sorry,
What worsens?
what it?
Worsens.
Nothing. I didn't notice anything that worsened it. What it worse?
Okay. Any feeling, any sensory alteration anywhere of this sensation?
Yes, doctor. Sometimes I feel a tingling and numbness in my feet and my hands.
Okay. And any weakness?
No.
Okay. And do you have any problem in your neck? Any pain?
No, doctor.
Okay. How is your walk? How is your gait?
Normal
In
gait.
Yeah, okay. Any fever?
No.
This feeling spinning, does it worse when you stand up or sit up from lying position?
Yes, doctor. Yes.
Okay. And do you feel along that any racing of your heart?
No.
Okay.
Sorry.
Sorry?
Yes.
Okay. Did you how's your do you feel any kind of sweating when you feel this spinning?
No, doctor. Actually, I don't. It takes seconds, doctor. It takes seconds only, or
Seconds. Okay,
minutes.
okay. What do you do when that happens?
I slow my motion, doctor. I slow my motion. If I standing, I stop. I stand for sometimes without motion, without movement, or sitting
Okay.
again.
Okay, and for how many times this happened? Like you said seconds, but how many times during the day?
Many times, doctor. Many times now. I
Many times.
actually can't do any work now.
Okay, that must be hard. Do you feel like you are um what else do you feel along that feeling of unsteady? Or do you feel um so um you feel tingling at the same time?
No, not say
Or-
sometimes. I said to you, sometimes I feel tingling
Yeah,
and
yeah.
numbness in my feet and hands.
Okay. Do you feel weak in your body?
No, doctor, you asked me before. No.
And I mean lethargic.
Yes, this is a text. Doctor give me make me lethargic. Me tired all the time. I can't do
Tired
anything
all the time. Okay. Is it worse in the morning or night or all the day? This tiredness
today. All the day.
in the day. Okay.
All
Uh,
the day.
all the day. Okay. Any? You told me there is no headache.
No, it's not.
Okay. Did you feel? Um, so let me ask you: do you have any past history of high blood pressure?
No.
Any high blood
I blood
sugar?
pressure. Yes, I have type 1 diabetes, doctor.
Type
Since
1
I was 7
diabetes.
years old. Yes.
Okay, okay. And how is okay, since when you have been diagnosed with type 1 diabetes?
7 years. 7 years. When I was 7 years old. Years old.
Okay, and do you take insulin?
Yes, doctor, I take insulin.
And how is your doses? Are they quite the same since for the past, or are they
No,
changing?
it's changing with time. I was
What
on
do you
regular
mean?
follow-up until
Okay.
2 years back. I lost my follow-up.
Okay. And what doses of insulin you take and for how long?
I take two types of insulin, which is long-acting and short-acting. I take
Okay.
long-acting once daily. I take short-acting 3 times per day with meals.
Mm-hmm. Um, okay. And do you experience episodes of low glucose, low sugar?
Sometimes, yes, doctor. Recently, sometimes I feel that I have many attacks of low blood sugar,
Okay,
and
okay,
I feel hungry and sweating.
okay. I'm sorry for that. Can I ask you about your any other past medical history then?
No,
Okay, any surgeries?
no,
May I ask you what is your medication list now apart from your insulin?
only insulin, doctor.
Okay. Any other over-the-counter medications you took?
Sometimes I take paracetamol for headache if I have, but nothing.
Okay. What about this headache? You told me. So is it
It is
severe
episodic.
headache?
No, no, no.
Episodic headache.
episodic headache, tension, and maybe tension headache or something like that. It is
Is
not
it coming?
frequent.
Is it coming in all over the head or a specific place in the head?
It is not frequent, doctor. It comes like bandage-like, and it is intention situation or something like that.
Are they linked to this? Are they preceded by any weird feeling?
By what?
Before the headache, do you feel anything like you are? Do you see objects or do you see floaters, something
No,
in
no,
the eye?
no, no,
Okay.
no, no, no,
Okay.
no. I said to you,
Okay.
this headache is not frequent.
Okay. So, may I ask you, how's your urine usually? Is it a more frequent urine do you experience?
Actually, doctor, not frequent, but there is some frothy urine
Okay.
recently.
And and any swelling around the eyes sometimes happens.
I'm not noticed. I'm not sure.
Okay. Any shortness of breath when you walk?
No, doctor. No,
Any chest pains?
no, doctor.
Any swelling in your legs?
My legs, no.
How's your back passage?
Normal.
Normal.
Some lose motion recently, but it is okay.
Okay. And for how long you feel this loose motion?
For also for 3 months now,
Okay.
but
Are
it is not
they
watery.
what color exactly? Are they, so they are loose.
I'm not
Are
there.
they sorry?
What, doctor?
Okay. Are they associated with sometimes heart stool?
No.
Okay. And are they hard to flush? I'm sorry for that.
I'm not sure, doctor.
Okay. Let me ask you, do you smoke, Mr. Ahmed?
No, doctor, I'm not sure.
And do you drink alcohol?
Occasionally, doctor.
For how long and how much?
Only in the occasions, very occasionally, maybe once by year, once or twice by year.
Okay. And what do you work for a living? I'm sorry. I asked
I'm a
you, but
teacher.
your teacher. And
I'm a teacher.
um, so this must be affecting you, right? These episodes.
Yes, doctor.
Okay, we will do our best and involve the social worker and occupational health. Is that all right for you?
Okay. Thank you.
Okay. And do you have any allergy to any drug?
No, doctor.
Okay. Are you married, Mr. Ahmed?
Yes, doctor.
And okay, Mr. Ahmed, can you tell me? I'm sorry for that. How is your relationship with your wife? Is it affected by diabetes, by this?
Yes, doctor. I have some problems in the relationship.
Okay, since when?
Since about I am not sure, but maybe for 3 months or 4 months now.
Is it a problem in the erection?
Or more than that, doctor. Maybe more than that.
Okay. So, do you mind if I do you drive, Mr. Ahmed?
Yes, I'm driving.
So these episodes, actually, I will advise you to stop driving until we sort out the reason behind that. Is that right?
Okay.
So let me examine you.
Okay.
I will check the pulse. Is it regular?
Yes.
Any pallor?
No.
I will check. I will auscultate any murmur of the heart.
No,
I will
no
uh,
nerve.
s- I will check if there is any tremors.
No.
Okay, any proximal myopathy?
Yes, there is proximal myopathy.
Okay, is any goiter?
No, no wait.
Okay, I will check the vitals. How is the blood pressure?
170.
Okay. Do you feel more irritable than usual at times?
I'm not sure, doctor. No,
Okay. Cerebellum, is there any past pointing and nystagmus?
no.
Okay.
I will
And
extend you 1 minute, Dr. Abdullah, okay? It's for the
Mr. Ahmed,
concern. 2 minutes with the concern. 2 minutes. Just
what is
finish
your
the examination.
concern? Yes, what is
What's
your
the problem
concern?
with me, doctor? What's the problem with me, doctor? Why these attacks? Why this business?
Okay, Mr. Ahmed, this is a genuine concern. Actually, it looks like you are having these episodes could be linked to, we are not sure about the reason, but could be linked to your high blood sugar and diabetes. And we will do measurements or observations or check on your kidneys and urine, and we'll treat you accordingly. We think that could be something related to with the diabetes affecting the cables and nerves. Do you want to ask me anything else?
It is curable, doctor.
It requires a multiple team approach. We will seek the opinion of the expertise doctors. It depends on the control, how deep the nerves are affected.
Okay, thank you.
No worries at all.
Examiner question?
Yeah.
Examiner question?
Yeah.
Okay, reset the timer. Wait. Yeah, start the examiner time.
What's your finding and what's your differential?
Okay. So this Mr. Ahmed is 35 years old, male, with a long history of type 1 diabetes. He has been experiencing features of vertigo worsening over the 4 months, along symptoms of nausea and other features of orthostasis. He has also, I think these are chronic manifestations linked to type 1 diabetes complications, because on examination I couldn't elicit from history and examination, I couldn't elicit any focal neurological deficit. And that's it. I couldn't elicit any medication related. He has erectile problem or autonomic dysfunction, and so that's my impression. My differential diagnosis here could be type 1 diabetes related complications. I mean autonomic neuropathy. Else can be other features such as autoimmune related conditions such as Addison disease. But against that, this is vertigo. And
why this vertigo? She said to you that is when standing from sitting position, it has this dizziness. It is a postural hypotension.
Yes, supported by the history. I would like to examine that further. and also given that there is proximal myopathy, this patient should be screened for other autoimmune conditions
Okay,
such as hypothyroidism.
okay. How
Yeah.
did you investigate this patient?
This patient requires basic investigations, requires blood count, full blood count, kidney function tests, especially urine, also including urine analysis in the bedside, and also urine protein creatinine ratio, looking for any proteinuria, and also looking for liver function tests. If also given the we'll ask about the lying and standing blood pressure, and also he will require testing for scans of his he will require scans of his cortisol levels, and if required
Okay.
Yeah.
You said this patient has postural hypotension. Okay.
Yeah.
What's the differential for postural hypotension?
So we have drug-induced postural hypertension due to medication effect, or can be hypovolemia related. In this patient, unlikely, because in this patient he could have orthostatic hypotension due to autonomic neuropathy. He could have
I asked you about the differential diagnosis of postural hypotension, not in this patient at all.
Okay. So could be autonomic neuropathy, could be hypoadrenalism, and could be postural orthostatic tachycardia syndrome.
Okay, time is up. You want to ask more, Dr. Shaima?
لا لا.
It's okay. If one more question, you can ask if you want. It's okay.
No.
Okay. Okay. So thanks, Dr. Shaima and Dr. Abdullah. Well done. Yeah, thank you. Let's hear the comment, then I will comment. Yeah, Dr. Shaima,
Actually,
please.
Dr. Abdullah, you did well, but there is some missing part. The case is autoimmune polyglandular syndrome type 2. As the patient has, you didn't ask about loss of weight. You don't ask about tanning of the skin.
I asked about weight.
About what?
The weight I asked.
I didn't remember you asked about weight. I thought there is weight loss, yes?
Okay, no problem.
There is weight loss, there is weight loss, and there is tanning of the skin.
Okay.
This patient actually had type 1 diabetes, type 2 autoimmune polyglandular syndrome. يعني هي the differential one of the differential autonomic neuropathy, second differential autoimmune polyglandular syndrome type 2.
Yeah.
You will add only بس in the investigation short Sneckton test and the anti-21 hydroxylase auto antibodies.
Yeah.
Okay. Differential diagnosis of postural hypotension, it may be, as you said, drugs as diuretic, or autonomic neuropathy, or some diseases like Addison, بانهايبوبيتوتاريزم، باركنسون، سيلياك، جوالين-بري syndrome, ايتون ليمبرت syndrome, any diarrhea or loose motion can cause positional hypotension.
Hmm.
So in this patient, I should admit him and do some investigation to see the electrolyte also,
Yeah.
electrolyte, and do ECG. لأن أديسون بيبقى فيها إيه؟ بيبقى فيها هايبر كالسيميا and هايبر كاليميا.
Yeah.
Yes.
But he doesn't have, right, this patient? I'm sorry,
doesn't
I've
have.
interrupted you. Continue.
Why she is didn't he didn't have? May
There's no
have.
hypercalcemia he has. He has.
Okay. We should admit here and do electrolyte يعني.
Okay.
Okay. if we يعني احنا لو هنعمل ريفيجن بسرعة كده على الاوتو اميون بليجراند سندروم تايبس.
Yeah.
هي تايب 1 تايب 2 تايب 3 تايب 4. تايب 1 بيبقى فيها كرونيك كانديديزيس وكرونيك هايبر باراثايروديزم واديسون. خلاص. اي اتنين من دول بس لازم اديسون، يعني اديسون في تايب 1 وتايب 2 لازم اديسون عشان اقول عليها ايه اوتو اميون جلاندولار سندروم تايب 1 او تايب 2 لازم يكون فيها اديسون. تايب 1 بيبقى لما اديسون معايا كرونيك الكانديديزيس او كرونيك هايبر باراثايروديزم، الاثنين او واحد منهم. تايب 2 اديسون زائد ثايرويد او بلس او ماينس تايب 1 دايابيتس. اوكي. تايب 3 ما بتجيش كتير، هي تايب 2 هي اكتر حاجه بتيجي. تايب 3 بيبقى ثايرويد اوتو اميون ديزيز زائد اني اذر اوتو اميون كونديشن ما عدا الاديسون، بس لازم يكون في ثايرويد. يعني تايب 3 بيبقى فيها ثايرويد زائد اي واحد تاني، زائد مثلا تايب 1 دايابيتس، زائد فيتيليجو، زائد مياسينيا جريفز، اي حاجه دي تبقى تايب 3 بس ما يبقاش فيها اديسون. تايب 4 any combination of autoimmune disease non including the previous groups، يعني حاجه غير بقى الايه الاديسون والثايرويد والتايب 1 دايابيتس، اي كومباينيشن بنقول عليها ايه اوتو اميون بوليجلاندولار سندروم تايب 4. بس
Yeah. Thank you. Nice case. Actually, I messed up. I feel I'm not organized very much, and I will improve on that. And the tanning was a very important key point. I missed. And all examination, I didn't do a lot of things and systemic review also. So
no problem دكتور، يعني احنا كلنا كده، احنا كلنا بنتعلم لسه طبعا.
yeah.
بس هو كان في كومنت كمان بس كنت عايزه اقوله، ان احنا عندنا لما يبقى في حاله يعني اعرف ان هي اديسون. الاديسون بيبقى ليها 6 سيمتومز تقريبا، 2 لوس اوف ويت ولوس اوف ابيتايت وتامي بين وتانينج اوف ذا سكين واتاكس اوف هايبوغلايسيميا واتاكس اوف هايبوتنشن اللي هو from sitting dizziness from standing from sitting position. خلاص، يبقى دي السيمتومز بتاع الاديسون. لما الاقي العيان عنده اديسون يبقى انا كده ممكن يكون اديسون لوحده، ممكن يكون اديسون بول اند اوتو اميون بوليجلاندولار سندروم تايب 2، يبقى ساعتها هيبقى معاه تايب 1 دايابيتس، وممكن يكون الاديسون ده داخل تحت بين هايبوبيتوتاريزم. فبسال على اسئله البان هايبوبيتوتاريزم اللي هي لوس اوف هير، لوس اوف ليبيدو، لوس اوف هير، لوس اوف بريست سايز، انابيلتي لاكتيشن لو ام عندها طفل. يبقى كده دي انا عندي ثلاث، يعني دول 3 حاجات لما الاقي اديسون يبقى ايه اخد بالي انه ممكن يكون اديسون لوحده او يكون تايب 2 او بس. شكرا.
طب why he has blood pressure high?
It's not high. It was 100/70.
Oh,
لا
I
انا قلت
heard
100/70.
Yeah,
Yes,
he heard it like
100/70.
170.
وانت يا
I
دكتور لو
heard
انت
it.
وقفته قلت I want to check him وهو واقف كنت هخليه اوطى.
Okay.
Yeah. Thanks,
Thank
Dr.
you.
Shaima, and thank you, Dr. Abdullah. Yeah, let's have the comment, and you will know the mistakes and the missing point where exactly. I will comment because I wrote every word you said. Okay.
Okay.
Okay. So it started by the complaint onset course duration. You wrong about it. You didn't ask them exactly the onset course duration by the exact question, onset course duration. You just try from here and there. That's why you being more confused. You don't know when it exactly started, what worse, what increase, what improve. So better to ask what the meaning of this business. What you mean? She said to you, I feeling spinning around the things spinning around me. And she give you a very clear and very nice clue. When I standing from sitting position, then you ask her, can you tell me what was it? She's saying to you, when I stand from sitting, it happened. So this is the clue of the case. You try again to ask her when. So it's clear that it's after standing from sitting or sitting from
But
lying. So yeah,
I'm sorry,
yeah,
but it shouldn't be spinning. That's what confused me from the beginning.
yeah,
It was
little bit.
idle, not dizziness at all from the beginning.
It's okay. You can put it as differential, but still you have a very big and major
Yeah,
occasion
standing.
while
Yes.
standing
Yeah.
from sitting. So this
Okay.
you make circle, big circle on this. Okay, then what improve? She said it's nothing improve it, but it happened for minutes, for seconds, and many times a day. Then you analyze more for the CNS. You don't have a problem with the CNS. Anyway, she told you there is a sensation affection. Yes, there was sensation affect and tingling of the hand and feet, and you link that to the diabetic and
It's
control diabetes. Yeah. The gait, you ask for the gait, and you went to the constitutional symptoms, but actually you ask for the fever and the tiredness. When you ask her for lethargy, I doubt about the lethargy as the jargon. I think it's jargon. So tiredness is the word. So you feel tired. She told you, yeah, all the day I'm feeling tired. You didn't ask about the weight. You didn't ask about the appetite. You didn't ask about the lumps or bumps, night sweats. You ask only for the fever. Yeah, I agree with Dr. Shama. You didn't ask for the weight because I'm writing everything positive and negative. Okay, then you went to the cardiovascular system, racing of the heart, yes, pain, chest pain, you ask leg pain, leg swelling, short of breath while walking or doing activity. Then the GI, very important clue, the loose motion, it was there. She told you
Yeah,
3 months. Yeah, watery, she said no, it's loose only. Flushable, she said, I don't know. So you have a clue now for your case, standing from sitting plus the loose motion. Then you miss the endocrine and skin and joint. But you ask for the genitourinary, the process of with the urine, which is related to the diabetes. You ask for the medical history, and she give you a history of insulin dependent diabetes type 1, I mean, and insulin compliance. You ask for these things, and you ask for the follow-up. She said, I am not following up anymore. I have another clue for the case. I have attacks of low blood sugar. You ask this question, and she give you honest answer. Yes, I have attacks. So you can correlate to the case here, which is Addison. The neuropathy you ask for the neuropathy. You didn't ask about retinopathy, the vision problem.
yes.
You didn't ask about gastropathy, feeling full after small meals,
Yeah.
and impotence. You condense more question about impotence. You said you have a partner, you have marriage. How is your relationship? It's clear question you can ask. You have any
Yeah.
problem with their intimacy? That's it.
Yeah.
Try to shorten the time because you didn't do family history, you didn't take travel history, the HIV, which is little bit important this patient if you suspect HIV and adrenalitis. So
Yeah.
you can quick review for the HIV. Over
Yeah.
counter you ask, yeah. Smoking is alcohol, driving, and job you ask. So you ask for the occupational and social except apart from family and travel. Then the examination already the time is up, but you tried to be targeting the examination, but you didn't do. The pulse you ask, the heart murmur, I don't know why you jump to the heart murmur directly. You ask for the proximal myopathy, you didn't ask about the blood pressure sitting and standing. Very important. Tremors, you ask, I don't know what the relation in this patient tremor. Goiter, she give you goiter, I think, or you ask about goiter, but you didn't ask about the thyroid swelling or other examination of the thyroid. Then the vitals, you misunderstand the blood pressure 170, but she means that 100 over 70. Then you ask for the cerebellum, and the time was for the concern. Cerebellum will be here intact, I guess.
So our differential Addison in the top, then you can put autoimmune polyglandular type 2, then autonomic neuropathy, you did this differential well. Hypoglycemia you can put as well. And the last one is related to the vertigo, as you mentioned. You can put benign, paroxysmal, positional vertigo. You can put it number 4, but it's not on the top. So on the top, the Addison, autoimmune polyglandular, and autonomic neuropathy, and you have evidence for each of them. The Addison for the diarrhea and standing from sitting, autonomic neuropathy, pins and needles in the legs, hypoglycemic attack. There was attacks of hypoglycemia, and as the spinning around, you can put benign, paroxysmal, positional vertigo. So this is the case here. I guess you think about something is very rare and you miss a very common diagnosis. Addison, it's a major topic
Yeah.
in the paces. Yeah, you
Yeah.
think about something else and you miss the major things. So
Yes.
don't overthink about the disease or the diagnosis and miss very important topic or very important diagnosis like Addison. Thank you, Dr.
Doctor, I
Ashima,
think
for the case. Yes, sure.
the first differential diagnosis here is the autoimmune polyglandular syndrome because patient has type 1 diabetes
Yes,
along with
I agree.
the
I said
special
Addison in the form of autoimmune polyglandular. This is number 1. Number 2, autonomic neuropathy. Number 3, hypoglycemia. Number 4, BBPV. This is so Addison as a part of
بس
components
يا دكتور
of
انا عايزه بس اضيف
autoimmune.
حاجه عشان دكتور عبد
Yeah,
الله
sure.
البناين بوزيشنال فيرتايجو بيبقى دايما العيان بيغير البوزيشن بتاعه وهو نايم
Yes,
يعني هو نايم في
from
السرير
from
بيغير
lying. Yes,
from
you're right.
side to side during lying
Yes.
position from side to side ده الكلو بتاعها ودي في الغالب
Yeah.
بتبقى ايه نتيكس يعني مش كتير بتيجي
يعني for the word of spinning, but it's not the major differential. If you miss, you will not be getting the mark. No, if you miss, you will not be deducted for the mark. But if you miss the Addison, you will be deducted. If you miss the autonomic neuropathy, yeah, that's it. Alcohol, you can put if the patient is drinking more alcohol. HIV, if you have risk of HIV, you can put autonomic neuropathy as well. So autonomic neuropathy is not only diabetes. You can put a lot of causes of the autonomic neuropathy under the term of autonomic neuropathy. Postural hypotension, you can mention them if the patient is taking some medication, diuretics. Yeah, there is signs of dehydration, complicated diarrhea. What else for the postural? Also the heart, but no heart history or no cardiac event here. No family history, or you didn't take the family history. I guess this patient will have some family history of autoimmune
Yeah.
because it's autosomal dominant, autoimmune glandular.
It's important.
Okay. Yeah. Okay. Any question, Dr. Abdullah?
Why I think my voice wasn't reaching at the same time, right?
That's why I give you 2 minutes for the lagging, no problem. But I want
was
you
lagging,
did
right? I thought
yeah,
Shaima was doing like more harder.
also Dr. Shaima lagging a little bit, but I give you 2 minutes for this reason. But I want you to be speedy
Yes.
as you present the case. You were speeding in this presentation. I have patient name Muhammad, but while doing history, you are talking very slowly and
Yeah.
comfortable. But this is exam. Try to speed up your history taking and examination because it's 15 minutes and a lot of things you might miss if you being like not slow. I mean, it's you feel like comfortable with the patient and take long time with taking history, but it's need to be speedy to get a lot of data in the history and the examination. So try to just speed your tone and your taking history, okay?
Sure,
Otherwise,
thank you.
you're on the proper and correct track, but just to try to practice more. Okay,
Okay.
let's have any question, Dr. Abdullah, before we
Thank you.
read the. Yeah, thank you too.
Thank you so much.
Okay, let's have the comments. Examine. Yeah, Dr. Roda also remind you to examine the patient. Please WhatsApp group link. Okay, thank you, Dr. Ahmed, for sharing. Dr. Ahmed again. Yes, in the start, she takes him to vertigo. Yeah, I agree. She gave him some clues about spinning, and this spinning let him spin. He was spinned because of this spinning, and he yeah diverted away from the case. But again, she gave him the positive clues, which is diarrhea and standing from sitting. Any for seconds, dizzy for second in BBPV. I don't know. I don't understand what the meaning of this. Yeah, it's
Yeah,
second while sleeping. And sleeping, like Dr. Shema said, when the patient is or the person is changing his sleeping side from supine to lateral, lateral left to right left. Sorry, from lateral left to lateral right, for example, he will be spinning. It comes before exam BBV. What do you mean? You mean the dizziness before?
BBB.
The case. Dr. Ahmed, you ask the case came in exam BBBV? I don't think so. Because, you will not find any finding in this patient. Only spinning while he's turning. That's it. I don't think it came before. If someone heard about previous exam scenarios, he can help us. Anyone heard about this scenario before?
هو دكتور صلاح
Even
بيقولها في الكورس بتاعه، فالدكتور صلاح دايما بيركز على الحاجات اللي بتيجي، ما قالش ان هي جت، بس بيقولها،
اه
بيقولها كويس.
okay.
يعني هو
Yeah,
الحاجات
put
اللي
it
كل
in
اللي
the
بيقولها مش فاهمها.
it's okay to put it in your mind and now the presentation of this patient, but you will not find anything else. You might have some imbalance due to inner ear problem, unsteadiness, intolerance to the loud, but I don't think anything else you will have in the patient
بعدين
unless the patient have. Mm.
لو انا شاكه فيها المفروض بسال على الاسئله كلها بقى عن الاير ديسيتشارج، الاير
Yes,
فورنس،
exactly.
الاير رينجينج.
Infection, yes, infection, previous ear discharge related to infection or trauma. Yeah, you're right. But unless the patient is with a chronic comorbidity, for example, diabetes, and this case came on top, like, for example, infection to the ear in diabetic patient, and he has the vertigo on top of this. So you will ask about the diabetes and so on. You will have diabetic history, neuropathy, nephropathy, and nephropathy and retinopathy and neuropathy plus the autonomic neuropathy, plus the other manifestation of diabetes, accumulated blood sugar. You didn't ask about hemoglobin A1C, Dr. Abdullah, in this patient. And this is another clue. You will have low hemoglobin A1C. It will be like 5 or 6, I guess, Dr. Shema, right? Because Addison make the diabetic more tight controlled.
Yeah.
Okay. Any question or any comment from others? Someone make a draw on the screen. Okay. Any question? I guess this is smiley face. Okay. If no question, Dr. Abdullah, can you write your scenario, please?
Yeah, I
The
wrote it.
scenario present in the group.
And that's
Someone
WhatsApp.
18 years old female with abdominal pain. 18 years old female with abdominal pain for 3 years.
Okay. Take 2 minutes, Dr. Shema, then we'll start. Lisa. Okay. Again, our famous name. Yeah, I remember one point important with the previous patient, the skin rash or darkening of the skin. You can check while taking the history, or you can doing
Yeah.
examination. Yeah, either the hand creases or the mouth, opening your mouth from inside. You might have this darkening or any scar in his body. In his body, you can ask, did you notice your scars being darker than before? Or any change of the color of your skin at all. This is by the history. But in examination, you can ask for the knuckles, for the creases, for the mouth, for any scar in his body, and you can notice the darkening. Okay.
Yeah.
Okay, doctor, we can start.
Okay. Let's start the
It's,
timer. Okay, Dr. Sharma.
Good morning. I am Dr. Ibrahim, the doctor in the medical OPD today. Nice to meet you. Are you Mrs. Lisa,
yeah.
18 years old?
Yes, I am, doctor.
Okay, Mrs. Lisa, today we are here to discuss issue related to your health, and I will examine you. Okay, it is okay with you?
Sure.
Mrs. Lisa, it came to my knowledge that you are complaining of tummy pain. Can you please tell me more about that?
Yes, doctor. It's actually something very like 10 over 10. It's very hard pain. It's very long time, but I was not bad with it, but now recently it came very bad after the surgery.
Surgery. I'm sorry for that. I can give you some painkiller if you want, if you need
Yeah,
now.
no worry. I have taken, the nurses gave me.
Okay. Can you please tell me, is it present all the time?
Yeah, most of the time.
Most of the time. You said after surgery. What surgery you did?
Well, I have been. They discovered uh, a cyst in my ovary, and they did surgery. But the pain came worse after the surgery. They thought the pain is from that, but I didn't
Mm-mm.
improve.
When was this surgery exactly?
It was 6 months ago.
Before this surgery, it was also there is abdominal pain,
Yeah. It
the tummy
was
pain,
like for 3 years. So the pain started 3 years ago.
3 years ago. Okay. Can you please describe to me this pain, the
Yeah,
nature of this pain?
this pain is kind of it's kind of like it's dull. I can't understand it. It's dull, all more in the lower tummy. It's dull.
Lower tummy. More in the lower tummy,
Yeah.
not all over the tummy. Only on the lower tummy.
Well,
Is it relief? Mm, yes.
uh, sorry. It's so it comes. It comes. Yeah.
Hello, Dr. Abdullah. I can't
Yeah,
hear.
I guess he's left.
Okay.
Yeah, he left, so we will join back. I already paused the timer for you.
Interrupted problem. Yeah. Interrupted. Yeah. Sorry.
Yeah, it's okay. We paused the time. Yes,
Can you
resume
please
back.
tell me the story of this pain, Mrs. Lisa?
Yeah, this pain actually it's more in the lower side of the tummy, but it's not taking one place. It's sometimes in the right, sometimes in the left. It's very hard to describe. It's dull, it's
Yes.
intermittent, but after the surgery, it became so unbearable. It's worse. I came. That's the story basically.
Okay.
Um,
Uh, hmm. Okay, I listen to you.
So
Is there
it's
anything
nothing clear to improve it, actually.
nothing to improve it?
Yeah.
Mrs. Lisa,
Sorry?
you said nothing improve it?
Yeah, nothing improve it.
Okay. This is Mrs. Lisa. This has been started with you from 3 years. Yes?
Yeah.
Since 3 years.
Yeah.
Before these 3 years, you were okay?
Oh no, I was sometimes I was having anxiety. I will go to the doctors. I have gone to this mood doctors for years also, but I'm now focused with this pain.
You take anything, any indication for your mood now?
No, nothing for the mood.
What about your mood now?
Yeah, not bad, doctor.
Not bad. Okay. Mrs. Lisa, returning back to the tummy pain. Do you have any it is go anywhere? Back pain,
No,
chest pain,
no,
any loose motion, Mrs. Lisa?
no,
Any change in bowel habit?
no,
Any tummy distension?
no.
Any throwing up? Any feeling sick?
Yeah, sometimes I feel sick with this so hard pain, but it's nothing. Yeah,
Okay. No throwing up.
no.
Okay. Any change in your weight?
No, doctor.
Did you notice anything that increases pain or decrease it?
No,
Like stress,
nothing.
like
No, nothing worsens this pain. It came on
special
all
food,
positions.
special
Hello.
food type of food, special type of food.
No, it's not related to the food.
Okay. Um, it is increasing with time.
Oh, yeah, last 6 months it's very unbearable.
I think after 6 months, it changes the nature or the same nature. Is
No,
this
same
is this
nature.
abdominal pain? Is this tummy pain like the first tummy pain before the operation, or different?
The same pain, yeah.
Same pain. Okay. Okay. Mrs. Lisa, do you have any weight change?
Uh, well, no, doctor. Well, doctor, this
Good.
pain actually, I'm sorry, doctor, this pain is worsened also. I have been on too many medications because they thought I have before the surgery, they gave me the pills. They thought to improve on the ovary. They thought I have been diagnosed with polycystic ovary, and they gave
Mm.
me the pill. I felt worse after the pills. They
What is
gave
this
me
pills?
yeah, or contraceptive pills.
Oral contraceptive pills. Yes. You
Yeah,
worsen. This worsens the tummy pain.
yeah, and I feel not. I feel actually worse after the anything that I take. They gave me medications. I feel worse. Yeah.
Okay. Is there any high body temperature?
No.
No high body temperature. Any tiredness? Any
No.
numbness or numbness?
No.
Any tiredness?
No.
Okay. You said to me there is no abdominal distension. Is this pain relieved by anything? By defecation? By painkiller?
No.
Nothing.
It's not.
You said to me
No.
nothing.
No. They give me
Okay.
painkiller. It becomes worse. When they
Okay.
try to painkiller, it becomes worse.
Okay. Any headache, Mrs. Lisa?
No.
Any dizziness?
No.
Any fits?
No.
Any weakness?
Yes, I have in my legs. Actually, this is since 6 months also. It has been, I feel my legs, my gait is becoming weird. I feel also tingling
Tingling and weird in your legs. Both
and
legs?
weak. Yeah, but worse on the left. Yeah, you can say both legs. Yeah.
Both legs,
Well, only the left. Yeah, it's worse on the left. Yeah.
left, mainly
Yeah.
left.
Yeah.
Okay. Present all the time, this weakness, or more in the
Yeah,
morning,
all the time. Yeah, all the time.
all the time. It is stiff, weak, is stiffy, or
No. It's
it is
no. It's
floppy.
usual. Yeah, you can
Floppy.
say normal. Yeah, not too much different. It's slightly floppy. Yeah.
Slightly floppy. Okay. What about your gait? There is no normal gait.
Yeah, my gait has been affected with this week and tingling. Yeah.
Okay. All the leg is weak, or the joints.
The left mainly. The right is
Left?
okay.
Okay. All the left leg is weak.
Not all
All the joints.
only down on the ankle.
The ankle.
Yeah.
Okay. If there is any trauma,
No.
any any trauma,
No
any
trauma.
hotness in any hotness, any
No
redness in your
hotness.
ankle?
No hotness.
No redness in your ankle?
No hotness. No. No swelling.
Okay. Is there any pain in your ankle?
Yeah, it's this tingling is kind of it's not pain, it's tingling. Yeah.
Okay. Is this pain or this tingling is with movement or after rest?
No, not related to movement or rest. No.
Only tingling.
Yeah.
All the time present? Nothing improve it?
All the time. Yeah.
Okay. Is this when this leg weakness starts?
Well, doctor, is it 6 months ago? Yeah.
6 months.
Yeah.
6 months ago after the operation?
Yeah. All came worse together. Yeah. The pain and the tingling.
After the operation.
Yeah.
Yes?
My tummy pain and yeah.
Okay. I asked you about any weakness, okay? Any chest pain?
Not chest pain. You asked me, doctor.
Okay. Any cough?
No cough.
Any shortness of breath?
No shortness of breath.
Okay. Any change in the bowel in the urine water work? Color, frequency, amount?
Yeah. Sometimes the urine becomes dark.
Dark?
Yeah.
When? In the morning?
Yeah.
Is it related to something? In the morning.
Well, you can say when it is it's not specifically in the morning, but I mean it's when it's outside.
When outside. When it leave it.
Yeah.
Oh, okay. It's become dark.
Yeah.
Okay. Is there any froth urine?
No.
Any weather preference?
No.
Okay. Mrs. Lisa, any past medical history or surgical operation other than this ovarian cyst should be aware of?
And the mood doctors. Other than no.
No. Okay. Mrs. Lisa, I am sorry to ask this question, but it's a sensitive question. What about your period? Is it regular?
It is fine, yeah, doctor.
Okay. Are you married, Mrs. Lisa?
No, doctor.
Okay. Do you have any partner?
No, doctor.
I'm sorry to ask you this question, but I ask it to all my patients. Any casual relationship?
No, doctor.
Okay. Any family history of similar condition, Mrs. Lisa?
No, doctor.
Okay, Mrs. Lisa. Any family history of NOT?
Of what?
Of NOT, يعني of high blood pressure, high blood sugar.
No.
Any family history of cancer,
Yeah.
sudden death?
2 minutes remaining, doctor.
No cancer.
Oh, Okay, okay. Can I examine you?
Yes, sure.
What do you do for living, Mrs. Lisa?
No, I'm a student. I'm low student. I'm fine.
Okay. Do you smoke? Do you drink alcohol?
No, doctor.
Okay. What's your concern, Mrs. Lisa?
دكتور باسم أعطيها 2 minutes والله النت lagging.
لا لا
Okay,
هكمل
I will
إن شاء الله
extend,
بس.
but yeah, try to finish. Yes, go ahead.
لا okay.
Examine me.
Mrs.
Examine me.
Okay, so I will examine you. General examination. Pulse.
Yeah, you look
Blood
normal.
pressure.
She looks
Look
normal. Yeah, look normal. Pulse is normal. Heart blood pressure is slightly high, 150/90.
150/90. Okay. High blood pressure. Okay. Mrs. Lisa. Mrs. Lisa, can I? Is there any pallor?
No. Yeah.
Okay.
There is mild pallor. Yeah.
Mild pallor. Okay. Mrs. Lisa, can do abdominal examination, please?
Yeah.
Any? There is a scar. By inspection, there is a scar.
Yes,
Of the
there's
ovarian.
scar.
Okay.
Yeah.
Is there any palpable masses? Any organomegaly?
No. Negative.
Okay. Do you smoke, Mrs. Lisa?
No. I don't.
Do you drink
You
alcohol?
asked me.
Okay. Okay. Well, you are a teacher, Mrs. Lisa. Okay. This affects your job and.
I'm I'm low student. I'm fine, thank you. Well, affected me very much, yes, doctor. But
I'm sorry for that. I will try to help you, and I will I will refer you to social. What's your concern, Mrs. Lisa?
what do I have, doctor?
From you said to me, and after I examined you, I think you have a condition called porphyria cutanea tarda. Acute intermittent porphyria. Acute intermittent porphyria. Don't you bother yourself by the name. This is a medical term for medical condition in which there is autoimmune disease. I mean, this is a defense disturbance in the defense system attacking your body instead of attacking the bugs, leading to symptoms that you have. What we need to do now is to do some investigation and some blood test and imaging. And I will sit with you I will sit with you again to discuss the result of this investigation and the management plan.
Yeah.
Okay, time is up. Yeah,
Okay.
good. You reached to diagnose after this scenario. Okay, let's have the examiner time, then we will.
Yeah. What do you think? You give me your findings and differential.
This is Mrs. Lisa, 18 years old, come complaining of abdominal pain since 3 years. She has a history of anxiety and low mood. And from the history, there is only dark urine and big abdominal pain. She has abdominal ovarian cyst and did surgical for that. Her urine, he said that her urine is become darker when become outside. So this is manifestation maybe suggestive of acute intermittent porphyria. Second differential diagnosis, maybe familial Mediterranean fever, but against that there has no family history of similar condition, no other no soreness no biliary, no joint pain.
Why do you think the patient has the feeling of weakness?
I think this is انا بصراحه مش قادره افتكر acute intermittent porphyria قوي، بس على قد ما افتكر يعني ان هي بتافكت السي ان اس وافكت الايه وافكت الكدني. انا مش قادره افتكرها قوي بصراحه. عشان كده عندها anxiety وعندها dark urine. انا مش قادره افتكرها.
It's peripheral neuropathy. It's
Yes.
mixed motor and sensory neuropathy that she has developed due to porphyria. What other main differential diagnosis be other than the familial Mediterranean fever?
Other than
In
familial
general,
for
in
the
general, in general, in this topic.
abdominal pain يعني for 3 years
Yeah,
Okay.
recurrent
abdominal
abdominal pain.
Yeah.
for long time إيه
Yeah.
I think the patient may psychological disturbance يعني something related to her mood anorexia nervosa or something like that but there is no loss of weight no
Mhm.
uh,
Yeah. He's asking for differential, Dr. Shena. What's the third differential for recurrent abdominal pain?
هو acute intermittent بروفيديا وفاميليا ميديتيريان فيفر وحاجه ثالثه بس انا مش قادره افتكرها برضه يعني
Okay.
التوبيك ده انا فاكراه بس مش قادره افتكره
You can read from the chat box anyway. Yeah, Dr. Ahmed mentioned. Okay, go ahead for the approach, investigation and management quickly. How to investigate Dr. Shema and management.
I will do a basic investigation and I will do urine analysis انا مش فاكره يا دكتور والله مش قادره افتكرها فعلا يعني انا
لا
It's
التوبيك
okay.
ده
Okay. Just Dr. Shema, don't stuck and say I don't know. Do all
okay
investigation, not specific. Do
Like,
the,
like
okay
the
basic
general
I will do basic
investigation.
investigation I will do basic investigation
yes.
in the form of TBC renal function liver function electrolyte inflammatory marker
Yeah.
I will
Yeah.
do abdominal ultrasound and I will do urine
Yes.
analysis and urine by إيه؟ by
Porphyrin. Yeah. Yeah.
Morphobiology.
وفي biology يعني.
Yeah.
I will do abdominal ultrasound
Mhm. Plus possibly CT scans, right?
yes
Okay.
for what CT scan?
Because it's acute abdomen case and to exclude any ischemic bowels.
Okay, and for the weakness, I will do nerve conduction velocity study, and I will do EMG, and I will refer her to multidisciplinary team, including endocrine, including neurology and
Porphyria team, maybe because they're a specialized, specialized facility. Okay, you did great. Thank you, Dr. Shema. You did great.
Yes, time is up. Yes. Yeah. Dr. Yes.
I was going to say just it's a acute medical abdomen. That's the topic. Acute medical abdomen. It's not only surgical. The reasons. So when you find patient did surgery and it's not easy actually, but it's a diagnosis of differential diagnosis of abdominal pain. So any case, it's good you asked on all the systems. Excluded chest pain, MI reasons, part of a workup, troponins and management, because it may present with abdominal pain. Also, you asked about chest. You covered all the GIT, and so it's also in the differential here, we have acute pancreatitis is important also, and it's she's young.
hereditary angioedema دكتور احمد تقريبا كتبها
Okay. Yes.
هم ثلاثه حاجات فعلا هم ثلاثه اللي بيعملوا acute pain abdominal pain for long time and usually patient تعمل operation هم الثلاثه دول familial mediated fever و acute intermittent porphyria و angioedema hereditary angioedema.
Angioedema. Yes. That's Dr. Basim. Please give us your nice comments.
Yes. Okay. Thanks for the case. Actually, we didn't practice this case for a long time. Thank you for bringing this case. It's a common case as a topic of chronic abdominal pain and recurrent abdominal pain, and as acute on top of chronic. Yeah, Rabia asked, is it acute? Yeah, acute on top of chronic, Dr. Rabia. You can say like that. Because patient came with a severe pain scale 10 out of 10. So it's acute on top of chronic. Let's have the comments starting from the analysis of the complaint. You took long, Dr. Shayma, for the analysis of the complaint. Abdominal pain for 3 years he gave to you, and the scale he gave to you 10 out of 10. All the time in there. The nature, you ask the site, the travel, or the where the pain goes exactly. You analyze the pain well. What worse, what improve it, and did it help with the painkiller? And he told you that I have taken the painkiller. Then you analyze the GI. It's great to do that in the same system, relevant system. GI is feeling sick, throwing up, the bowel habit, it was loose, alternating with constipation, food type related, it's not. So you analyze the GI. But you took long. I don't know why you took long in this. Maybe 4 or 5 minutes in the GI and the analysis of the abdominal pain and GI system. Then you took long for the CNS, which is your triad, your patient classic symptoms. The CNS, the mood, he has mood disturbance, depression mostly, and the weakness. You took long for the weakness, floppy or not. What, where exactly the ankle, the fits, you ask, yes, and the tingling. He just give you the hint, but you ask him more. That's why I wrote for you in the chat box. Hurry up! It's one of the component, yes, but you should analyze more for the other system review and the other exaggerating factor. Still, you have a lot of things to do. Cardiovascular chest pain to rule out MI, or as Dr. Abdullah said, yes, okay, no problem, cough and short of breath. Genitourinary, he gave to you that it was dark when it leaves. So it's clear when it is standing or on standing, it turned dark. Yeah, so this is acute intermittent failure. It's now you have the 3 triad: depression, and the peripheral neuropathy, and the darkness of the skin. Sorry, darkness of the urine on standing. Plus the abdominal pain recurrent on and off, and the severity. The whether the endocrine, you roll out female history, he gave you a history of ovarian cyst. This is one of the also differential. Ovarian cyst might be rupture of the cyst on top of ovarian cyst. You can put it, but you analyze it well, and he did surgery for that, or she did surgery for that. After that, she took the OCP, which worsens the symptoms, the hormonal worsens the condition. Then the female history, as for the periods, the skin you miss, the joint, you may ask about joint while asking for the ankle. Yeah. Family history is important. Yes, it's autosomal dominant, by the way. As you mentioned, autoimmune. No, it's autosomal dominant. So you can explain by this. If you don't know, don't say autoimmune. You don't know, tell him, I'm not sure about the mood inheritance. I know about the exact code of this disease. Just give him unclear words, because it might be clinical judgment against you, because you give him wrong answer. Autoimmune, it's not autoimmune. Medication or medical history, you ask for surgery, but you didn't ask about any over-counter medication, or what else you took, any long-lasting disease. You ask for long-lasting disease. Partner, you ask for the HIV risk here, any casual relationships, but you talk long. I prefer to finish the case. Target question. I guess you know the case, but you didn't target your question.
I
And
didn't know the case until the dark urine. Before
yes,
that,
I guess so.
I think it's a familial
Yeah,
Mediterranean fever.
try to, yeah. Okay.
So I take took long time for the weakness. It is joint pain or it is
Yes,
weakness. I take long
it's
time for that.
yeah, you took long in this. It's just peripheral neuropathy with some affection of the nerves. So just ask about it and try to collect the other component of the disease, which is the darkening of the urine and the mood you already he gives to you. And try to hurry up for the examination because you have examination. Vitals, she is hypertensive and pallor. I don't know why pallor in this patient.
Anemia of chronic disease.
Okay.
Yeah, I actually forgot to tell. It should be also with eating. Yes, with eating it improves. Yeah, yeah. I'm sorry
Okay.
for that.
No problem. The constitutional symptoms you asked Dr. Shaima, the weight, the appetite, the temperature, the lumps or bumps, and tiredness. Yes. And then the differential in this patient, the examination you did abdominal examination. This is the target. You do abdominal examination for the abdominal pain. Where exactly and try to do inspection, palpation, percussion, and auscultation as usual. You might not find any positive because it's just like no organic reason, I mean, for this. But do it in the steps way. Then the differential of our patient, as mentioned, acute intermittent porphyria, familial Mediterranean fever, hereditary angioedema or angioedema, irritable bowel syndrome, lucidly possible. And you can put ovarian cyst and on top of chronic ovarian cyst like rupture of the cyst or just related to the menstruation might be related to that. So our case was acute intermittent porphyria, autosomal dominant metabolic disease, and the manifestation we mentioned, starting from up the headache, sorry, the depression, abdominal pain on and off, colic 1, constipation, some vomiting, and sometimes the urine darkening or standing, port wine called port wine urine. Sometimes we have peripheral nerves affection. Okay, and this is for the manifestation. The laboratory, as you said, don't just say I don't know this disease. So the examiner will not leave you. What do you mean by don't know this disease? Just tell any investigation you might do, and it might help for reaching the diagnosis and to rule out others. What if you said I will do lipase and amylase? Is it harm?
Yes.
You can
No.
do it. Why I think about chronic pancreatitis. Okay, you can take mark for this, but don't say I don't know the disease. Just mention general investigation, okay? Then a specific investigation for the disease, then association or complication, then imaging. Imaging, as Dr. Abdullah said, you can do ultrasound. You can even do ultrasound for the polycystic ovarian. You can do to rule out any complication of the cyst. You can do CT if you are suspecting pancreatitis. Just talk. Don't say I don't know. Okay. This is for the investigation. The target investigation here, urinary porphobilinogen. It will be high, some association of hyponatremia and sciatica, and that's it. The confirmatory test you might do genetic testing as it's autosomal dominant condition. The management, high carbohydrate diet. This is very important, okay? High carbohydrate diet, starting by non-pharmacological, of course, multidisciplinary team approach. Then non-pharmacological, patient education, counseling about disease, and try to train your tongue how to talk, even I don't know what is the disease. Just to utilize the time, I just mentioned some lines of management. It will give me marks without touching the disease or the diagnosis. Okay, patient counseling education. Did it harm? Nothing. Do you know the diagnosis? I don't know, but I should say that. Okay, still you didn't have the diagnosis because you have to do a laboratory test. So I will start by this multidisciplinary team approach and patient non-pharmacological patient counseling, education about the disease and the complication and the association and how to avoid the exaggeration, what the exaggerating factor like that. Okay. Then the pharmacological one, as I told you, carbohydrate, high carbohydrate diets. And in the attack, I can consider some strong painkillers like narcotics. And also in the attack, I can use hematine. This is one of the management, pharmacological, I mean. And you can use glucose infusion. dextrose 5% infusion for in the same attack. I mean, okay? Hematine is the pharmacological target medication. That's it. So you can just be simple in the presentation and talking in a smart way. I don't know the disease, but I don't know how to approach and to investigate and to manage without even reaching to diagnose. By the way, most of this disease you can't conclude them by just doing examination, taking history. Yeah, sometimes the history will help, but there is the laboratory. What about the laboratory test? What about the investigation and the imaging? You are not alone in the hospital to diagnose a disease by yourself. Even to involve the hematology, as mentioned by Dr. Ahmed, yes, hematology one of the important dimension of the team. Other team, gastroenterology, gynecology for the polycystic ovarian. So don't stuck while saying what I can do, I don't know what to do, and you will be stressed, and you will be more stressed in the next question. He will ask you, you'll be more stressed, and you will not answer him, and you will lose all the case. By the way, I wanted to give you a mnemonic for social. I am always using it to take a history. I'm doing family, travel, medical, and HIV. This is my way to take this history by word Fatma. Okay, Fatma. Fatma for F for family, T for travel, M for medical, and H for HIV. Fatma. Always I'm using this approach in order not to miss any of the social. I will share it to the group, and as well I will share it to the chat box. For the occupational job, do you the job first, then do you smoke, do you drink alcohol, and the driving, do you drive, do you drive, you smoke, do you drink alcohol, what's your job? So this is the way how to take the history without missing these things. Try to write it down in the paper, like do you questions which are, do you drive, do you drink alcohol, do you smoke, and the job. And the social, I will ask for Fatma, F for family, T for travel, M for medical, and the medical means everything: allergy, surgery, medication, and long-lasting disease, not only medical. Okay. Then the HIV means the casual relationship, the sharing needle, the recreational drugs, the blood transfusion, and piercing and tattooing. This is in case you have patient suspected HIV, you should ask all these questions. But if you have patient not related, try to make it quick question like casual relationship, that's it, or intimacy, according to the case. I will try to share this to be beneficial for all. And yeah, let's thank Dr. Yeah, thank you, Dr. Abdullah. Thank you, Dr. Abdullah, for the case, because yes, long time we didn't practice this case. And try to bring more different cases. Yeah, thank you, Dr. Shema. Well performance, but as I told you, try to just utilize the time by smart sentences. I am not that smart doctor to reach the diagnosis, but I am smart enough to convince the examiner that I did everything without knowing the diagnosis. Even the investigation I will do, it will help me to reach the diagnosis, although I don't know the diagnosis. General investigation, specific complication, association, like this. Okay, it's a matter of practice only. Yeah. Thank you so much, Dr. Shema. If any comment, let's see, read in there. Okay. Any comment written here? Fasting, alcohol. Yeah.
Yes.
Dr. Ahmed?
Yes, Dr. Basim.
Yes, sure.
Assalamu alaikum.
Alaikum salam.
Just I want to add something. If we have a patient with recurrent or long time abdominal pain, we should ask about previous attack. Or do you seek a medical advice for this or not? Okay.
Yeah. Go ahead.
Yes, something oral contraceptive abdominal pain increases oral contraceptive pill هم حاجتين تمام اللي هم ايه الاكيوت intermittent porphyria ولا الهيباتيك ادينوما. اوكي
Okay. Yeah.
ايوه دي اكتر حاجتين بيزيدوا مع شنو مع الاورال كونتراسبتيف بيل تمام. الهيباتيك ادينوما دي سيرجري. الاكيوت انترميتد بروفيريا هي باعتبارها ميديكال كيس. بخصوص الدكتوره قالت في الديفرنشال انه فاميليال ميديتيريان فيفر ما في فاميلي هيستوري. فاميليال ميديتيريان فيفر هي اوتوسومال ريسيسيف والاكيوت انترميتنت بروفيريا اوتوسومال دومينانت. In such cases, in these cases, there is no family history. We cannot exclude. Maybe this patient adopted or something. Okay.
Yes, Dr. Muhammad, thank you. Yeah, I agree with you on this point as exaggerate. But by the way, you said for the previous attack, he already gave her that by himself. He said, or according to the surrogate, as she has this since 3 months, sorry, since 3 years on and off. So no need to ask because he volunteered give it. But if he didn't mention, we can yes ask it in a previous attack. But it's written there 3 months, 3 years, and he already gave it. For the alcohol, yes, I agree. The steroidal for the OCP, yes. By the way, also OCP worse the migraine. The migraine also worse by OCP, especially the combined one. Just to add to your point, acute intermittent porphyria and migraine headache and hepatocellular carcinoma. I'm not sure. You said hepatocellular carcinoma or adenoma?
Hepatic
please.
adenoma.
Hepatic adenoma. Okay. Yeah, this is new for me. Okay, thanks, Dr. Muhammad. Dr. Rabia, yes? You raise your hand.
Dr. Basim explained everything really well. Just want to add a little bit comment. The first thing, Dr. Sharma did a very good history. The day Dr. Abdullah was saying yes to everything, and Dr. Abdullah was not clear about the history very well. Because Dr. Sharma asked the question again and again, any worsening of the pain, did anything? He said no. Then in the middle, he said OCPs increase the pain. So, Yani, it was not a very clear history. And then what is the foot pain? Yani? What foot pain will come with acute intermittent porphyria? It's usually a motor neuropathy. There is no environmental joint pain. Tamam, there is only motor neuropathy. You can have some tingling and numbness, but it's very rare in 5 to 10% of the cases, okay? It's a pure motor neuropathy. Patient can come with foot drop and patient can come weakness, and it's usually asymmetrical. They will never come with bilateral weakness of lower limb. Okay, it could be a mimicker of GBS, but less likely. It's usually asymmetrical. It's motor neuropathy. There's no sensory neuropathy in acute intermittent porphyria. Okay, so I think Dr. Sharma did very well, and she took everything. She took a great history. I think she just missed a few points, which is not very necessary, but everything was positive. Abdominal pain, urine, weakness was too many questions because she could not reach it because it was very, the surrogate was explaining in a difficult way. So that's why she was again floppy, stiffy, which part I cannot walk, I cannot on my body. So I think she did really well, but it's to be sure, yes, it's Dr. Ahmad said, it has to be recurrent abdominal pain, and Dr. Basim, it will be very acute pain. You cannot ignore it. It will not be like for 3 years and coming and going, coming and going. Patient had to visit the hospital and should be done some investigation.
Admitted. Yes,
should be
admitted with management. Yes,
It will not be managed at home just like this, or it will go spontaneously by itself. It has to be managed by some medications. So usually they have acute cases, acute abdomen. This is the diagnosis of acute abdomen, not chronic abdominal pain. They will have recurrent attacks, but it will be very acute. Patient will not sit at home. It has to be investigated before. So that's the only point I want to add, okay? And well done, Dr. Shah.
Thank you. Thank you so much, Dr. Rabia. And well done, Dr. Shima. Yes, you being distracted a lot in this case. So yeah, I hope the next time it will be more professional. Thanks, Dr. Rabia, for the comment. Any other comment? Let's read. I like the mnemonic. Sajid, Dr. Ahmad mentioned Sajid also. Yeah, everyone has his mnemonic. Just try to remember whatever you are using. Smoking, alcohol, job impact, driving for social history. Yes, this is for occupational. I put do you smoke? Do you drink? Do you drive? And your job. Okay, it's okay. Whatever the mnemonic, just try to remember. I'm not convincing for my approach. I'm just helping if someone doesn't know how to follow or to have some mnemonic and he is missing, for example, travel and infection, it will be very pathognomonic. If you have patient with infection and with travel history and you didn't ask, you might lose the case for example, traveler diarrhea from the name, traveler diarrhea, and you didn't ask for travel, and the examiner will ask you, did you ask for travel? Yeah, sometimes we are missing points, but sometimes it's not necessary. For example, in this patient, why I will ask for travel, but in other cases, it's very important to ask for travel. So I'm putting as mnemonic, and the case you need to ask, just click, I ask. If no, no need to click and just make a or align or just ignore it. Okay, hereditary hematologist, acute intravenous fasting, alcohol, non-steroidal venous trigger was acute or yes, okay. Any question or any comment? The color changed to red when exposed to light and air, yes. Means on standing, when you leave it or on standing for time. Yeah, this is diagnostic one. Okay, thanks, Dr. Muhammad. Any other comment, any question before moving to the communication? So, Dr. Sarah,
Yes, I'm here.
oh, you want to start? You want to give me the case?
Please give me the case, please.
Okay, I will write it down.
Okay.
Dr. Sarah, you can read the scenario loudly, please.
Okay. Mr. Smith, 75 years old, diagnosed as COPD, admitted with pneumonia and intubated, connected to mechanical ventilation and shifted to ICU. And after days of management, he is not improving, and the multidisciplinary team decided withdrawal of machine and the end of life care. Sit with his son, Mr. Adam, address his concern.
Yes.
Okay,
2 minutes, then
couple of
it starts.
minutes. Okay. Um,
Okay, ready?
okay.
I'll show the timer. Yeah, let's start.
Hello, I'm Dr. Ghanem, doctor in clinic today. May I confirm I'm talking to Mr. Adam, son of Mr. Smith, 75 years old?
Yeah, I am doctor.
Hello, Mr. Adam. Are you
Hello,
next of
doctor.
kin to Mr. Smith?
Yeah, doctor, I am.
Okay. Okay, we are here to discuss some issues related to your father's health condition. Is it okay with you?
Sure, doctor, I came for that.
Okay, before we start, if you need anyone to attend meeting with us, ask for support. It's okay.
Why, doctor? How is my father, doctor? Tell me, please, doctor. How is my dad?
Okay. Please, can you tell me before, what do you know about your father's health condition?
Yeah, doctor, what I know, my father always suffered because of this disease in his chest, always connected to machine at home. Then when he's tired and sick, I'm bringing him to the hospital, and he's using a lot of medicine, inhaler. But I don't know, doctor, what happened for the last time? Why he's so sick?
Oh, I'm so sorry for your father, Mr. Adam. It must be hard for you. I'm so sorry. Okay, and what your expectation about our meeting?
Doctor, I think he will be improved like every time, and I will take him home. Please, let me take him home, please, doctor.
Okay, I appreciate your feeling, Mr. Adam. But I'm so sorry. I have uh, um, some information that will not um, is not um, is hard for you. I'm so sorry for that.
What do you mean, doctor? What do you mean by hard? Is he fine, doctor? Just tell me, what happened to my dad?
Okay, I'm so sorry to, I'm afraid to tell you that your father condition is acutely deteriorating, and now there is no active, known medicine can help him.
Doctor, every time he's taking this infection, and every time he is connected to this machine, and Every time everything will be like this, then he go home. That's it.
Yes, Mr. Adam. This is a condition that he is every time come to hospital and take this medication, but in this situation, he is not improving and his condition is deteriorating, and we can't give him any medicine can be good to him. I'm so sorry for that.
What you mean, doctor? You will not give him any medication? You didn't give him antibiotics, doctor?
This will not benefit him at this time. Now all what we can do is giving him the supportive care only.
What you mean by that, doctor? You will let him die, you mean?
I appreciate your feeling, Mr. Adam. I know this is hard time. Um, I mean that your father um, is now need um, to have supportive care only, and there is no active medication can help him. We will provide him the best of care that he needs, um, but we cannot give him any other treatment. And I'm so sorry to tell you that we will take him out of the machine, the mechanical
Oh,
ventilator, I mean.
oh my God. What do you think, doctor? He will live long?
This is difficult to answer question. Uh, it is hard to answer it. But I tell you that there is no um, active treatment for him.
Doctor, you are keeping saying no active treatment. What you will do, doctor? You will just let him die? Tell me, doctor. Be honest,
No,
doctor.
no. We will give him any care he needs, and we will treat his symptoms accordingly, and we will give him painkiller, and we will take care of his feeding and all this. But his condition is rapidly deteriorating.
Yeah, doctor, I understood that. Please, doctor, please. What I want now, I don't want my father to suffer, doctor. Please, let him die in peace. If you mean that, doctor, I am the one begging you. Please, let him die in peace, doctor.
Okay, Mr. Adam. I agree with you. Both of us need him to die to spend his uh, uh, days in peace and not suffer. We will work together, and he will need social support, you and your family and friends to be with him, and also psychological support, um, and to be with him. Okay, is it okay?
Yeah, doctor, this is what I need to my father. I don't want him to suffer, doctor.
Okay, I appreciate your feeling. Um, okay. Um, may I ask you if he has any wishes or written
Ye-
any advance directive?
Doctor, every day my father expressing that he doesn't want to suffer. That's why I'm telling you, this is his wish, doctor. Always expressing that.
Okay. Um, okay. Okay. We will have a team of specialists to take care of his condition, including supportive care doctor and social and occupational worker, and also Macmillan nurse and a specialized nurse to take care of his condition. Uh, okay. Um,
Thank you,
is
doctor. Thank you.
Okay.
Okay, doctor.
Uh, uh,
I am only, I not only the one dependent on him, doctor. I have my brother as well, and he will come from far away, doctor. Can you, doctor, let my father for some few hours till my brother will come?
Yes, yes, of course. We will wait for your brother. Um, um,
Okay, doctor, thank you for that. So you will let my father connect it to the machine till my brother will come from Canada?
yes, we will let him. Okay.
Okay, doctor, thank you for that.
Okay. Do you
Doctor,
have any other concern?
yeah, I have another concern, doctor. If
Hmm.
you remove this machine, doctor, for how long my father can live?
It is very hard to tell. Um,
Okay,
it may be a matter of days to weeks.
okay, doctor.
Okay.
Doctor, I have another concern, doctor.
Okay.
Uh, who will give me the papers, doctor?
Okay. If any paperwork, the social workers will help you in that.
Okay,
Okay.
yes,
Mm.
doctor. And who will help my mother? She was also dependent on him at home.
Okay. Also, occupational and social services will take care of this.
Okay, doctor, I'm worried my mother will know this news, might be shocked. Can you help me in this?
We will arrange a meeting with your mother, and we will talk with her in a very empathic way, and we will tell her the condition uh, and uh, and help her to absorb this job.
Yeah, doctor, please, doctor, don't hurt my mother. She is also sick and she was loving him too much.
I'm so sorry for her and for you.
Okay, thank you, doctor.
Okay, thank you.
Time is up. Okay, thanks, Dr. Sarah.
Mm.
I don't know why you kept quiet most of the time, but let's address the concerns together. Okay, but well done.
Okay.
You address the concern after I offer it, but you should do it. Okay, so this scenario may be new for you,
No,
but
yes.
yeah, that's why you should put your skeleton of sentence and questions you will ask, and you will be ready for this question what I asked. Okay, let's start from the beginning. You introduction was great. You introduce yourself. You ask for the next of kin. Yes, great. And you invite someone to support me was very helpful because yeah, I might need support because my father, yeah, as you said, in the scenario end of life care, so I might need support. What I know about the condition, I explain to you and I give you more about his suffer with the machine at home and medication and multiple admission. These points you might give by yourself and you can repeat it before giving the shocking news. Why we are decided for that? Because of what your father suffered from, starting from the machine, the disease, the infection, the antibiotics, the admissions, and so on. Use it as a weapon, okay? And you ask me for the expectation. Great. I told you, yeah, every time he's admitted and I'm going back with him. But this time will be different because his condition this time is, as you said, severely deteriorated. You can say worsening than the previous attacks and worsen more and more and might deteriorate his life. Okay. So you start to give me the hard news. I have hard news for you. It's good to start with this. Or you can prepare me well by saying your father is elderly one and he has a lot of complication due to the chest disease and multiple admission to the hospital. He suffered a lot. I know he's so precious for you, but this is the life and just be like preparing me for the shocking news now, which is, yeah, your father is worsening day after day. He's not responding to the medication at all. Even we connected him to a machine through his mouth and going to the throat just to support his breathing and try to overcome this problem and this infection. Unfortunately, he's not responding to our medication and his condition kept deteriorating. Although what we did everything for him, all teams did all support for him, but no response. So, doctor, what you will do? What's your plan, doctor? You will let him die? Be honest, yes, be honest and clear. This is your scenario and this is your task. Why you are not saying it? Yes, what you will do? What you think if you remove the machine or you the scenario is end of life. He's going to die if you let him die. If you remove the machine, he will die definitely. Say it. I ask you 3 times maybe. Will you leave him die? I'm afraid. Be sympathetic and empathetic and tell it. We are doing that in the practice, by the way. I'm talking about ICU. We have this such patient of keeping deteriorated septic shock, multi-organ failure, and we are saying this message clearly. I am not making some change of the plan or being wrong or wrong false hope for the patient message. No, we are giving the clear and honest message, which is your father. Yes, I am afraid. You can say like that. I'm afraid. Yes, but he will die in peace. We will be sure that will father will not suffer anymore. We don't want to let him suffer again and again. He suffered a lot, and we did everything for him, but he's not responding. So what we will do now, and this is decided by the multidisciplinary team approach or the group of specialists, and they think that your father will not respond anymore, and they decided to remove the machine. You didn't. You give me this sentence one only. We will remove the machine. So, doctor, after the machine, what you will do? Nothing. We just give him some painkiller to confirm and to be sure that he is dying in peace and no pain he will suffer from. Don't tell me supportive because I will not support him. I will let him die. What the support you give him? Even the eye fluid, they are stopping. The inotrope, they are stopping. The antibiotics, they are stopping. End of life care mean just oxygen, maybe feeding or eye fluid, but even that they can stop it. End of life care means that he will die within minutes, not weeks or days. If I remove the machine, by the way, and we switch everything, he will die. Maybe maximum hours, maximum, maybe day, but he will not survive more than this. So be honest and be clear for the message. Yeah, I'm afraid to say that yes, we tried our best and we did everything for him, but he's not responding anymore. That's why the team decided that we will remove the machine and we will be sure that he will die in peace. Doctor, he was wishing that. Even I tried to help you, doctor. His wishes was not to suffer. Yeah, we appreciate your father wishes. That's why the decision will be in the best interest of his condition. And our team decided not to let him suffer more. Even he thank you for that. Thank you, doctor, for appreciating my father wish. And the next concern, yeah, can you wait for my brother to come from another country or long suffer, sorry, for a long travel? Yeah, we can, if we can do that. But actually, your father might also um, die before, but we will try to do our best. But I'm afraid to say that his condition might not survive long or extend long, or to be more for waiting for your brother to come from the other country, for example, Canada. Okay. Who's dependent? You ask me now. Who's dependent in your father? Me, doctor, and my brother, my mother. Do you need any help? We can arrange a meeting with you. Try by the way, the question I ask you, you should do it, not me. But because I saw you little quiet, I asked this question. But you should offer these things for any end of life care. Any family dependent, anyone need help, and the advanced directive, no lasting of sorry, no, uh, it's called LPA. Okay, you'll not ask for that because power of attorney, because you will not change the decision. It's already taken. How many minutes, doctor, or for how long he will live after or survive? I'm afraid to say it's a matter of sorry, a matter of hours, uh, maximum 1 day or max few hours. You can say, as we know the time frame. We are not giving like a number, so we can say few hours. If he extend, okay, this no one can interfere, but few hours. This is expected. And if you see the patient with such condition, even hours he can't live. Sometime before that, I mean minutes. Maybe he is not reaching an hour. So this is the scenario. The dependence, yes, you should be, and the debriefment team. We said that before, the team who can sit with the family to give them the shocking news and to support them as well. Okay, be sympathetic and empathetic more, Dr. Shema. Sorry, Dr. Sarah, and this is the scenario. If any question, we can receive any question or comment. I hope it's clear, Dr. Sarah.
Yes, clear.
I'm sorry, I tried to make a new scenario because yes, we are practicing a lot of scenarios, but this scenario not practiced before. So end of life care different than palliative care. Palliative care,
Yes,
patient
yes.
might
I mix
yeah might
both. Yeah.
yeah no, this is different totally. Palliative
Hmm.
means I will give everything to be sure that he's living in a good way, quality
Yes.
of life to be good. But he will die. When he will die, no one knows. He might survive longer than the intact person. Why? Because might give him chemotherapy, for example, or cancer with some chemotherapy, palliative chemotherapy, palliative radiotherapy. He might respond. He might not. But it's different than end of life. End of life means I will switch the machine. I will switch the all support, and he will die definitely. And the Macmillan nurse you mentioned, she's
Yeah.
not here. She's in the
Yes.
yeah,
Yes.
in the cancer.
Okay.
Yeah, so specialized nurse. She will take
No,
care of him.
specialist.
Yes, and not
Okay.
support. This is not support at all. Just be sure that he will die in peace and try to save his dignity as much as we can. That's it. Okay.
Okay.
Any comment or any question? Any question? Dr. Ahad, this is you. Dr. Ahad. Long time you didn't join us. If you are Dr. Okay, if no question, no comment, we can move to the next slide. Please write it, Dr. Sarah.
I put it in the group.
Okay. Okay, the scenario, family of a patient under your care on the stroke ward requested to see you. Patient Thomas Devey, 52 years, as was admitted 8 days ago following a CVA. CT showed a large MCA territory infarct. He has made little or no improvement since it happened. He has a dense right hemiplegia with a homonymous hemianopia and a severe dysphagia. He has poor sitting balance and has an NGT tube in place. Medication aspirin, atorvastatin, paracetamol PRN. So, Dr. Sir, I will sit with the son, right?
With
Or
a wife,
the family?
let's say Miss Laura, with a wife.
Okay. So, no task, just I will sit with. Okay. 2 minutes, then we'll start. Okay, let's start.
Okay.
Okay. I'll adjust the timer. Hello there.
Hello.
This is Dr. Basim, the doctor in the stroke unit. You must be Mrs. Noura.
Yes, doctor.
Yeah, we are here to discuss about Mr. Dav Davidson
Thomas.
condition.
Mr.
Thomas.
Thomas. Yes.
Yeah, and may I confirm his age, please? He's 55.
52. 52 years old.
52. Okay, Mrs. Noura. You are next of kin of Mr. Thomas.
Yes.
Okay. Uh, we assume that we have permission from Mr. Thomas to talk about his condition.
Yes, doctor.
Okay. May I ask you what you know so far about Mr. Thomas' condition?
Okay, doctor. My husband was admitted last week with a stroke. He is quite unwell. I feel quite unhappy about the care he is getting. I saw various nurses and only one doctor see him in this last week. I have been given little information. I feel that I am kept in the dark. I don't know what is going on.
I'm so sorry to hear that, Mrs. Noura, and I'm so sorry for what happened and misunderstanding. May I ask you what's your expectation about this meeting?
Okay, doctor, I don't know what is going on with him. I want to know um, how is he doing, um, how is his recovery will be. Um, and no doctor talk to me except but you.
Yeah, okay, we are sorry about that, Mrs. Noura, and I'm here to address all your concern. Please, if you have any other question, you can stop me and ask what you want. That okay.
Okay,
So, you know about Mr. Thomas' condition already, right? Or you want me to explain more?
please, doctor, tell me what's going on.
Yeah, so starting from the stroke, you know about the stroke, right?
No, no one sit with me, and no one tell me
Okay.
anything.
Again, I'm so sorry for that. And so let me explain what happened with Mr. Thomas. From the start, Mr. Thomas came with the side weakness and he was admitted to the stroke unit as he having what's called stroke. So the stroke means that one of the major blood channel of the brain getting blocked by a blood clot. And for this reason, he has the symptoms, what I told you about, like weakness, some vision affection, and some difficulty of talking, some difficulty of swallowing. Are you getting me?
Will this symptom will be permanent? Will not he recover?
I appreciate your concern, Mrs. Nourab. I'm afraid to say it might extend long. However, we will do our best to try by our expert and professional team to make these things improve even little bit. Are you following?
You mean the recovery will not be complete?
I appreciate your concern. Yes, I'm afraid to say yes. It's difficult to be complete recovery. However, even little recovery, this is our goal in Mr. Thomas' condition, and try to make it gradually as much as we can by our expert team and professional nurses.
And doctor,
Are you getting me?
also, yes, and also his work is keep contact me about his condition and what should I do with this.
Yeah, I understand how difficult for you to hear all this news and to be with him in the coming days. And I'm afraid to say that you need a lot of support. And don't worry, we will provide you all the support we can to help you at home and how to care with Mr. Thomas. And our nurses will sit with you and they will educate you how to deal with his tubes, his care, and anything he might need in the coming days. Is that okay for you?
Okay, doctor, but I am not convinced that he is given the care he needs. The care is not enough.
I appreciate your concern, Mrs. Nora. Mr. Thomas, in condition that this, I'm so serious to say that this support and the care he's giving for long-term disease like stroke unit patients, this is the maximum support we can give to him in this situation. And don't worry, we will try our best to convince you and to see what you want more to do.
Okay,
Is
doctor,
that okay?
do you think I should transfer him to a private hospital?
Appreciate your concern. Your concern is valid. Actually, this is your right. If you want to do, uh, yeah, this is your right to do. However, the maximum support and the maximum care will be the same in our hospital or uh, in other center. I mean,
Hmm.
Okay, that's
You
okay
mean
for you.
you mean this is the maximum help that you can give?
Yes, yeah, our team already give and provide him the maximum care he needs in his condition.
Okay. Can I ask about the physiotherapy?
Yes, it's a valid concern. Yes, our physiotherapists are following him, and we can also arrange a meeting with them to sit with you with them and to sit and to know what we can do further at home. And they are concerning for his condition even after going home. Are you following me?
Yes, I'm following you. And what about his speech?
Yes, our speech, our swallowing and language therapists are following him and they are doing the maximum support he needs and they are assisting him his swallowing every now and then to assess if he is able to take by his mouth or just he will be kept on this tube in his nose.
All right, doctor. So I
Okay,
will tell
so
his his work that this condition is will take a long time. How
uh,
long do you think?
yeah, it's different from patient to patient, Mrs. Nora. Yes, I can provide you with our report to provide to his job company. May I know what's his job before?
He is a teacher.
Okay, so we can arrange with our occupational worker to sit with you and to address this concern. Is that okay for you?
Okay. Okay.
May I know who's dependent on Mr. Thomas?
Me and our children.
Okay, I can ask if you need any support or any kind of support I can provide you.
No, no. For now, no. Thank you.
Okay. We will arrange with our occupational therapist to come with you at home to arrange some furniture at home to be suitable with Mr. Thomas to live with. Is that okay?
Will I take him home?
If his condition will be suitable to go home, but before that, our occupational therapist will come with you to arrange these things. Is that okay?
Okay. Okay.
Okay, and we can also arrange a meeting with our nurses to sit with you to teach you how and to educate you how to sit with to take care of Mr. Thomas, his tubes and his care and what the maximum support he needs. Is that okay?
Okay. Okay.
Okay, you have any concern?
No, thank you.
Okay, I will provide you some leaflet brochure and the website about the post-stroke physiotherapy and the care for possible support he needs in this period in the coming days. And don't hesitate to call us by our contact number I will provide. Is that okay?
Yes. Thank you.
Okay. Thank you. Time's up.
Okay.
Okay, tell me.
Okay, doctor. You did well. You answer all her concern. Um, well done. Um, the points about the discussion. First, the consent, and you asked about this. And the next skin, you asked about this. The breaking bad news, and you talk about the stroke. And that was extensive stroke in the middle cerebral artery, and that he cannot move and cannot speak. Um, you address this and explain this for his wife. Also, um, you said about the physiotherapy and the swallowing issues and this and the speech team. This okay, but as long when he started to move and started to recover, and this recovery will may take long time because of the extensive stroke. And about the private hospital, this is you answered right, and he have all the care he wants, and you will help her if she insisted. But there is nothing to be done more than this is done in our hospital. That's all.
Okay. The NGT, the care, everything addressed in correct way.
Yes.
Okay. The occupational therapist. Yeah. What about taking him home? You ask me. You give me.
She cannot take him home until he start to recover.
It's suitable. Yes.
This is
Okay.
difficult for now. She tried
Yes.
to take
Yes.
him home, but he refused. Okay.
Yeah. Okay. I just tried to mention the occupational therapist to arrange his home to be suitable for him if he's okay to go home. Yes. I agree with you.
Um,
But when he recover
yes,
well, yes, after
yes,
assessment.
he is telling her that this may take long time until he can go home.
Okay. Okay. Thank you, Dr. Sarah, for the
Thank you.
scenario.
Mm.
Any other scenario, or sorry, any other comment or question? I don't know today, either too much understandable or too much sleepy, the candidate.
I think
No
it's
comment.
sleepy.
Yes, Dr. Mansour, Dr. Ihda, yes, sure. Finally.
السلام عليكم.
وعليكم
Dr.
السلام ورحمة الله
Passing,
وبركاته.
regarding scenario, my idea about starting for this scenario post-stroke care. So starting from the beginning about the sequel, about the vision, about the word speaking, about care for balance, about feeding and care for nasogastric tube. I think the scenario discussed as this way, or in the way of starting the stroke from the beginning of a stroke.
Yeah, I was ready to talk about these things. I wrote it in my paper, but
Yeah.
when she gave me that she doesn't know anything, that's why I went through that. I explained the stroke from the start. But if she knows and she will be addressed about the coming plan, I will talk about the care of NGT, the physiotherapy, the SOL team. Even she offer it, but I wrote it, so I'm ready to offer it. But if she asks as a concern, I will address it. Regarding the complication or the possible plan, if if she knows the disease, I will tell her the next plan. But she doesn't know. That's why I went through. So whatever, it's not clear. I mean, in this scenario, what's the task? That's why I was waiting for the surprise. What she will tell me, what she will ask me. But if the task is clear that this is post-stroke care, I will talk about these things. But actually, she surprised me when she asked about the disease and tell me from the start. That's why I kept explaining it. But the plan, or sorry, the task here is not clear. Yes, Dr. Sarah, you can tell.
Okay, this scenario was not to talk about the stroke as breaking bad news. No, it was about the concern of the wife that he is not recovery, not getting any recovery, and that the relation with the nurses and she didn't meet except one doctor, and she didn't even met the nerve doctor, and about physiotherapy. Um, and about the work. She tried to take him to a private hospital, and nothing about the stroke as a disease and its complication, and how to deal with it.
Okay, so it's up to the scenario.
Yes, this is the scenario that I
No,
saw.
sorry. Yeah, according to the concerns of the wife, it's not
Yes,
a clear task. That's why, Dr. Ihda, some scenarios, the task is clear and you will try to do it. And sometimes during the scenario, the surrogate distract you away from the task. And this way, you try to stop him and go to the task, because if you lost the task, you will lose the mark. And some scenarios, like this scenario, just you have the task during the scenario, because it's not nothing written in the scenario. A patient came admitted, then diagnosed, then now sit with the wife. What I will do? It's not clear. So what you will do? Try to
Answer
write
her
some
question.
sentence. Yes,
Answer
answer her
question.
question and try to make major things to write it in your paper if you have time to ask it. For example, the NGT, you should address it by yourself. For the care and the SOL team, I wrote it here. SOL team, one of the important team here. That's why when she asked me, I answer her directly because I prepared the answer. The physiotherapy, because he's hemiplegic and he will need physiotherapy. I wrote it as well. Occupational therapist, I wrote it because if he need to be shifted to home, he will be arranged at his home to be suitable. The dependence, this is very important. Who's dependent on him? You should write it, and you can ask her when you have time. So no one can have the clear task in some scenarios, and other scenarios you have the clear task, and you should do whatever that surrogate is distracting you away from this task. Try to stop him and to address the task or to do your task, even he's distracting you away from that. For example, a patient with suspected meningitis, and the task is to get consent for LP. Your task is LP consent. And that the surrogate keeping asking for what the sequelae, what the father, what happened, what, and so on. And you reach 8 minutes without talking about LP, you might fail. You have 2 minutes only, either to address the concern or to get the consent. Anytime you have a pause or you have a chance to stop him and to talk about the LP, do it. Try to do it from the start, after explanation the disease and your introduction and so on, expectation and the explanation, then direct give the clue about the LP and we need to do and take consent. Take him to your task. Don't let him take you away from your task. If you
That's my
lost the
target.
time,
Yes, that's my
yes,
target. Regarding to talk about blood thinning medication and lipid lowering medication, usually in previous session, the same comment you should stuck to the information in the scenario. So if all target to answer the concern of the patient, we missing some information in the scenario should be discussed.
okay.
That's my point.
Okay, any sentence here say that your task is to explain the medication,
No,
patient
but
on
it's
medication.
already
Yes,
written.
yes, whatever.
You
طيب,
may
most
say it. You may just enumerate this, but
Yes,
without
yes.
any explanation. You just enumerate it, and also the symptoms. Just enumerate it as a symptom of stroke, but without explanation. Also,
Okay.
that's what happened in the case. Is that what I saw in the case?
Yeah, by the way, Dr. Ihda, the task will be clear. Your task is 1, 2, 3. But patient mentioned in the scenario, medication, aspirin, atorvastatin, paracetamol, Piran. So what the task in this? I will just explain the medication. If she asks me, I will tell her, yes, there is medication. He will be kept on like aspirin and balastinin and so on. If I have a chance, I can offer it. No one will tell you why you didn't mention, and no one will blame you why you mentioned. But according to the scenario here, it's unclear task, and I'm waiting for the consent from the wife. That's my task. This is what I consider. Task come in the scenario itself. What she asked me, I should address in the proper way and in correct way. If I have time, I can ask for something important, might be important for the examiner, like dependence, like something he need support he needs. But if no time, and she kept asking me for that, and no task, no clear task, from where I will ask the task, because no clear task. This is
Okay.
my opinion, okay? But be sure that the coming scenarios or the current diets scenarios are clear. NGT, big tube, for example, procedure, or sometimes breaking bad news, medical error. This is a common scenario nowadays, medical error. So it's
Yes.
clear, medical error. You will talk about medical error steps. This is my point.
Okay.
The task will be clear. Okay.
Okay. Okay. Thank you.
Most welcome, Dr. Ahda. Any other question? Any other comment? Any other awake candidate? Dr. Dalia, are you there? Awake and slept every day? Sorry. Sorry for this question. Okay. Dr. Saleh, have you a question? Any comment?
No, thank you.
Okay, it seems that our session today very clear. Let's end the recording before enumerating for tomorrow candidate. Okay, thank you all for a nice session, nice cases, nice performance. See you tomorrow.